Thank you. All right. So the patient is a 33-year-old African-American female, 39 weeks, G4, P3, really a low risk, multiparous woman, small, BMI is 26, and she was admitted for induction of labor. Her cervix was favorable, and she desired to go ahead and have delivery occur. So, and this occurred at one of my referring hospitals in the past, and so I was consulted on this case after the fact. So that's how I know about this particular case. And she had a history of what was believed to be ITP, but had never been treated. She actually did have a hem-onc person that followed her, and she saw the hematologist once a year, had never had to have any medications, and she had no prior surgeries.
Dr. Campbell, could you kindly just, for those of us who might be like in here for learning for insurance purposes, can you tell us what ITP stands for?
Yes, immune thrombocytopenic purpura. So an autoimmune disease that leads to low platelet count. Next slide. There. Right. So her history, she had 3 term vaginal deliveries. The largest was 8 pounds, 4 ounces. The smallest was 6 pounds. Her last pregnancy, she did have a postpartum hemorrhage due to uterine atony and was transfused 2 units of blood. The estimated fetal weight in this pregnancy, 7.5 pounds. Again, no prior surgeries. She does have a chronic iron deficiency anemia. Her last hemoglobin in the office was right around 10, but the hemoglobin on admission before the induction was 7.9, and no other problems. Her admission vital signs: blood pressure 110/60, little tachycardia with a pulse of 110, normal respirations. Again, her hemoglobin, her platelet count was 166,000, 8,000 white blood cell count. She was type and crossed for 2 units, given her history as well as anemia. Baby looked great on the monitor. She was having contractions every 5 to 8 minutes and no decelerations and good variability. So her labor course was pretty much unremarkable. She had spontaneous rupture of membranes shortly after arrival, and Pitocin had been started, and her labor went very quickly. She delivered within 4 hours, 7 pounds, 12 ounces, with Apgars of 8 and 9. Her estimated blood loss was 400 milliliters, a little atony, but she responded well to massage and oxytocin. Her pulse was 122 after delivery. Blood pressure normal for her, which was, she normally ran between 100, 110, over 60 to 70. O2 sats normal. Really no symptoms at all. Did very well. Had the baby on her chest, and the bleeding was really well controlled. Next slide.
So Barry,
Yes.
did she get an epidural?
She did not have an epidural.
Okay, thanks.
She did not. So I had the question for management, wondering, just giving you the opportunity to say whether you might consider transfusion. I'll tell you, they transfused this young lady because of her anemia and the 400 cc's of blood loss, as well as the rapid pulse, just because they felt that she was going to be significantly anemic after that blood loss at delivery. So they went ahead and transfused her without doing a CBC. They ordered a CBC the following morning. So she was given these 2 units of blood without incident. She did fine. Her postpartum day number 1 pulse was 124. Her blood pressure 100/58. O2 sats were good, and she was afebrile. Really no complaints at all. Felt great. Her post transfusion hemoglobin went up to 9.9. Her white count was 5,000, and platelets were down to 145. Fundus was firm and non-tender. Her lochia was really minimal. The extremities were non-edematous, and she just looked good. So next slide. So postpartum day 2, she really felt great, no problem. She was up, moving around, eating, drinking. Fundus was non-tender, lochia was minimal. She was really ready for discharge. The obstetrician was called to see her before she went home because her pulse was just persistently over 125. It was anywhere from 125 to 135. Her blood pressures were normal again for her, 95 maybe a little bit low, but she always ran a low blood pressure. And she was afebrile. Her complaint was mild dizziness upon standing, but she was going to the bathroom and having normal bowel movements and normal urine production per her. Would anybody do anything? Donna, do you have any comments? If nobody else does, would you do anything differently for this lady?
So, in my mind, when I looked at the labs and her vital signs, my differential diagnosis was one, anemia, just like they thought, but I think I would have repeated the H&H first. I also thought of thyroid disease, but again, and that usually doesn't present like that. And the third thing that I thought about was sepsis. So, the reason I thought that sepsis was probably my number one diagnosis is because her white count went down to 5,000. Now, I mean, I'm not really concerned about a white count of 18,000, 20,000, as much as I am concerned about a normal or a very low normal white blood cell count in the postpartum period. Because when patients labor, then they almost always have an elevated white count on postpartum day number 1. And so if all their vital signs and stuff are stable, then I'm not concerned. But this lady, she continued with the tachycardia. She had a little bit drop in her platelets, which I don't know what to take of that in light of her ITP. But the white count really worried me.
Yeah, and I think that's one of the things that I wanted to stop here when we were going to talk about the plan and discuss how you would work this patient up. And I think you have to evaluate thyroid because we certainly can see thyroid abnormalities present like this. I think you have to rule out anemia, but I think and you know, this is the first presentation in the series on sepsis. So you've got to have sepsis in the differential diagnosis. And it's just one of those things where all the things you just pointed out are exactly right. The rapid pulse and the platelets even dropping a little bit, but that white count is more concerning. So again, they didn't order thyroid studies. They did order another CBC. They asked for orthostatics to be done, and they were normal. Her repeat CBC showed a hemoglobin that was essentially stable. Platelets, you know, who knows? They were 166, 145, now 135. WBCs are 4.5. And it's just not a good trend. I mean, I'm like you, Dr. Johnson, I would prefer to see a higher white count than a low white count. Physical exam, though, is what really lulled everybody down the path. There was no findings. She had normal physical exam, normal O2 sats, normal temperature curve. Everything just looked great. So where would you go from here?
So the one thing, Barry, the other thing I think we should point out here is that this patient was afebrile, okay? And I don't know what her actual temperature was, but in thyroid disease, they tend to go up. And in sepsis, they can go down. The patient constricts their periphery and they can go to like 96.8 or 97.2. And if you got a drop in white count and a low temperature, that concerns me too.
I agree wholeheartedly.
O2 sats in sepsis most of the time are normal unless there's evidence, unless the cause of sepsis is from pneumonia and they get ARDS, okay? And physical exams, the only way a physical exam can help me is if she, like this person had an abscess on her leg that wasn't seen when she came in for labor and delivery. I mean, because postpartum sepsis usually doesn't have any signs on their physical exam. They could have a little bit of a boggy uterus, but I'll be honest, I've never looked at somebody and said, well, she's got a little bit of boggy uterus. I wouldn't be able to tell if it's a little bit boggy versus, highly firm if she didn't have bleeding. And so you have to remember that with sepsis in the postpartum period, the patient is going to look normal. Now, she's got an abscess or something on her body. That's where I'm going to be thinking that the sepsis is going to come from, not her uterus.
And I think that is the whole point of this. I think it's the antithesis of what we're taught as medical students and residents. And we're lulled into that path as attending physicians out in practice, is you expect to find something on exam or with the temperature or otherwise when a patient has or is developing sepsis, and it's not necessarily the case. And I think that is the point to make. Let's go on to the next slide, Rachel. So the docs did the right thing by deciding to keep her for another day in the hospital to just watch. They weren't sure what was going on, and she looked great. She was alert, and the only finding on postpartum day 3 was the same thing, rapid heartbeat. Next. So they did repeat her CBC that day. And you can see that her white count falls more, her platelets fall a little bit more. She was afebrile, pulse is 132. And the good urine output, when the question was asked, well, how much urine output did she have? It was just the patient stating that she was making good urine. It was not quantified at all. Next. Her exam continued to be benign. Her lochia was almost non-existent. Fundus was really firm and non-tendered. She was not edematous. And the patient was absolutely insistent that she was going to go home. She did not want to stay any longer. So let's go to the next slide. So the doc, not sure what was going on, asked for the hematologist to see her. He was up doing his rounds, and he went in and he was reassured by everything that he saw looking at the patient, and said, I would repeat her labs later, and if they look the same, maybe we can let her go home this afternoon. And the obstetrician came by and saw her a couple of times through the day. No changes. She was just really very angry and wanting to go home. But the obstetrician, because of the rapid pulse and what he just thought, well, I'm going to go ahead and start antibiotics. We'll give her a dose of Rocephin and see how she does. And the patient kind of decided to cool her heels, and she was a little bit better. She ordered some Taco Bell and was little bit happier with that. So he ordered the Rocephin at 3 o'clock. They went to redraw her labs at 5 p.m. and the patient was confused. Next slide. So they called the obstetrician, and he was in a delivery, couldn't get to see the patient, and the patient collapsed. Nursing called a rapid response 15 minutes later at 5:15. The ER physician came upstairs. Again, it's in a smaller rural hospital. Ran the code, intubated the patient. Labs, WBC was 2,000, hemoglobin 12, platelets 92, creatinine 2.6, or AST was 120. Antibiotics were given, pressors were given, and interestingly, the patient had not received the antibiotics that were ordered earlier. They had not gotten up from the pharmacy, so she was never given antibiotics. The resuscitation was unsuccessful, and there was a maternal death within an hour after the intubation. Next slide. And obviously diagnosis of septic shock. I didn't add to those labs, but the lactate that was drawn during the code was over 4, less than 2 being normal. So it made it pretty obvious. Let's go on to the next slide. So the cultures on this patient grew out group A strep sepsis, puerperal sepsis, the old terminology for it, and Dr. Johnson and Dr. Gailey remembers this well. We used to see it a lot more commonly than we fortunately do now. It is a serious cause of postpartum morbidity and mortality if it's not treated aggressively, and it can be a great imitator because these patients may look very well. Now, they certainly can have fevers. I've seen these patients have very high fevers, but most often they lull you to sleep because they look so good until they don't look good. And one of the focuses that we will have in this series is to talk about sepsis, suspected sepsis, and how to treat these patients aggressively with the suspicion of that sepsis in the differential diagnosis, even if you're not certain, with aggressive early starting of antibiotics. That is the number one thing that is associated with survival in patients with sepsis, is early beginning of antibiotic therapy. Next slide. So just a few slides about sepsis, and then I'll open this up for discussion. A really sad case, and unfortunately, one of those things that can happen to anybody, and I've seen it more times than I'd like. Donna, would you have done any other labs in all of the workup of this patient than was done? You know, she just had CBCs done throughout her postpartum course.
So when you were going through the labs, I basically thought in my mind, I would like to see a PT, a PTT, and fibrinogen to see if she's in DIC, because I have a feeling she might have had a low-grade DIC. And I guess this is a fault of mine, but if I don't understand what's going on, I do get just a BMP.
I do too, and that's one message I want to drive home more than anything, because with these patients, when you're confused about the picture, get a broader set of labs. We as obstetricians tend so often just to get CBC. And with sepsis, it's a life-threatening organ dysfunction, a total body organ dysfunction caused by a dysregulated host response to infection. So what you'll see is you'll see a bump in the creatinine, and you'll see a bump in the liver enzymes, and you'll see a bump typically in the coagulation study. So what you're trying to, if you're trying to convince yourself that this patient is well or not well, broaden your scope, broaden the area that you're going to cast the net to review, get a few more labs that are going to help you. Because if you do a CMP and everything is cold stone normal, then I do feel a little bit better about things. Next slide.
What does the DIS stand for?
DIC?
DIC, excuse me.
Yeah, that's disseminated intravascular coagulopathy, where they develop coagulation abnormalities. In response, it's again part of that multi-organ dysfunction. It leads to the onset of consumption of the coagulation.
So Gary, there's one other thing that I would have asked for, but I don't know about in your hospital. In our hospital, this is very hard to get now. I would have liked to have a peripheral smear on this lady, to make sure she doesn't have any kind of abnormal forms of white blood cells. But the other thing is, she probably had a left shift that was sky high.
And they did not do a differential at any point. You're exactly right. I would have at least asked for a differential with my white count. And you know, the thing about peripheral smears, I think they're very helpful because they also help with the concern for breakdown of hemolysis, so that you can look for Burr cells and schistocytes. But you have to think about it, and you have to order it, and the pathologist has to do it. And most often it doesn't get done, but we do it. We just have to order that and have it done. I think that's a great point. And in this particular patient, particularly with her platelets falling, and you even have a hematologist involved, and that still didn't get done. And again, the emphasis has to be on organ dysfunction, not signs of infection. And that's where we as physicians get confused in these cases. And what I do a lot faster too with my labs is I'll order a lactate much more quickly than I ever have. It's an inexpensive test. And if you have sepsis even close to on the radar, lactate can be very, very helpful. But this lady hadn't had any of those things done. So we were really kind of behind the 8 ball from the beginning on her. Do I have any more slides? Not sure if I do or not. Okay, septic shock is a subset of sepsis patients where the underlying circulation and cellular metabolic abnormalities are profound enough to substantially increase mortality. Basically, they're spiraling at that point. Sepsis with persistent hypotension, requiring vasopressors to maintain their mean arterial pressure, and their lactate is generally over 2 in septic shock. So by the time you get to septic shock, starting antibiotics at this point is generally fruitless. You have to get treatment started before they reach septic shock. If you get to this point, the mortality is tremendously high. Maybe this was my last slide.
Well, just a question, because as I'm recording, I can't see the chat. I see that a chat came in. Just, is it a question, a comment, or is it just maybe someone giving information?
Let's see. No, that was just
Just giving information.
Thank you.
information.
But Barry, the other thing that happens to us is we get lulled to sleep by the fact that we are dealing with a condition and not a disease. Okay, pregnancy doesn't cause any harm to the patient. We don't think, at least. And so it's not a disease like lupus or hypertension or diabetes. So they're healthy people, And then sometimes small people, especially your BMIs of 19, 20, they have a low blood pressure. But it's the tachycardia that is not normal that we have to continue to look at. And the one of the group A strep sepsis that we took care of, that I've taken care of, that was her only sign when she went home. She went home for like 12 hours, stood up and collapsed, and then her husband brought her back to the emergency room. And that basically was the only thing it could be. But the tachycardia is really abnormal.
It really is, and we just have to pay attention to that and have it on our radar. And that's the whole purpose of us going down this path, to talk about sepsis and pregnancy. I can't look at the next. Is there another slide? So yeah, so group A strep sepsis, the old term for it was childbed fever, puerperal sepsis. It was a common cause for death pre-antibiotics. It was very common. And the use of empiric antibiotics for patients who were suspected that could have this has really saved a large number of lives. But we still see it. I've seen probably a death a year, either in our population of referrals or talking to people from group A strep sepsis. So it is not a rare entity, and empiric antibiotics can save lives in situations that are unclear. And again, making the point of full lab evaluations, including a lactate when you're not certain what is going on. And then the last slide, I remember the last slide now. This tachycardia, again, just to say, we get lulled to sleep by normal postpartum patients. This was a low risk patient. She looked great, felt good, and we just need to act more aggressively when we see something like this that may be of a concern to us. So anyway, I wanted to use this case to kind of open the discussion for sepsis